Hi, good morning. This is Colin Barker from Methodist DeBakey Heart Center, and we have with us today Dr. Gregg Stone from Columbia University in New York City, and we just heard from him a really landmark presentation regarding the CoAPT trial in treating patients with functional MR using the mitral clip with medical therapy versus medical therapy alone. So thanks, Gregg, for coming to Houston, and welcome. And
thanks,
again,
Colin. My pleasure.
Congratulations. I mean, that was really, there hadn't been anything like that in a while, along with TAVR. But I think what we'll sort of do today is sort of go over, how you got where you are. And there's a lot of people out there who are envious or aspire to be someone and as productive as you have. So maybe going way back,
Sure.
what was the initial sort of drive to go into medicine? When you were younger?
Well, it's interesting. I grew up in Shaker Heights, Ohio, suburb of Cleveland. Real traditional Midwest values, and no one in my family had ever been in medicine. For some reason, ever since I was young, I was always interested in science, though. I had, big chemistry lab. I was kind of making computers in the early days of computers. I did photography and other things like that. And then I did have one kind of transformative moment. I think I was probably about 15 years old, and I had a summer temporary job as an X-ray transport orderly. I was pushing patients from their beds down to X-ray at Mount Sinai Hospital in Cleveland. The hospital doesn't even exist anymore. And I remember there was one patient that came in, a young man who had been in a motorcycle accident and had aortic dissection, and was, precardiogenic shock and was dying. And I rushed him down, to get his films done. And then he went to the operating room. It was like 8, 9 at night. And I stayed with him throughout that whole time. And I actually stayed with him when he got out of the OR. And he actually survived a traumatic aortic dissection. And that was very motivational for me. I thought this was absolutely incredible. I mean, he was only probably about 26 years old. And so I could somewhat identify, and I could say what an amazing impact, that this had on this person's life. And I think from that point on, I really wanted to be a physician and work with patients.
Was there a similar sort of aha moment for cardiology or interventional cardiology?
Probably not a single aha moment, but cardiology for me has always been kind of the right mix of being a macroscopic enough topic. So I can visualize it in my mind, I can understand the pumping chambers of the heart, I can understand blood flow, and at the same time, I think once interventional cardiology came out as a subspecialty, so it wasn't just more of a thought exercise or a pill-pushing exercise, but we could actually do something to actively help patients, that kind of did it for me. So it was a combination of being able to do repairs, being able to directly help patients in an immediate, 1-2 hour time frame, and hopefully transform people's lives for the better.
Were there one or two people that were sort of mentors or particularly influential, in your early career that sort of guided you or helped you out?
Yeah, I mean, I've been very fortunate. I've known just a lot of great people at every step of the way. I went to the University of Michigan undergrad, and I, even back then, was interested in science. So as an undergraduate student, got hooked up in a basic science lab that was investigating prostaglandin biosynthesis. Back then, this is in, what years? This is probably in the mid-70s. And prostaglandins were brand new. They were the hottest thing. And most people never even heard of them before. And I was at one of the labs, a man by the name of William Lanz at the University of Michigan, who was investigating, again, the synthesis and metabolic pathways of prostaglandins. And so I went to him as a undergrad, and he took me under his wing. I remember he gave me a book of abstracts. I remember this like yesterday. It was a blue book that was this thick that had abstracts from a symposium. There were like no papers yet published, but people were starting to present a lot of research on this. And he said, just read this. And so I'm starting to read like 1,000 abstracts with all these words. I had no idea what they meant. But worked with him for a couple of years, and helped develop ways to look at rat perfusion, kidney models, and measure prostaglandin levels, different concentrations of oxygen and other things like that. And again, so he was a great early influence. Then I went to medical school at Johns Hopkins, and became very involved at that time, actually, in electrophysiology. And a real mentor at that point was a man named Phil Reed, who was a cardiologist, electrophysiologist, pharmacologist, really ended up ultimately going to Lilly, but a real Renaissance man. And he introduced me to Michelle Morawski, who developed the first automatic implantable defibrillator. And they were working on it at Hopkins at the time. So I got very involved in electrophysiology, became one of the readers for the hospital. That was kind of a new thing. We would get, studies like with paper. It'd take you like 4 hours to read an EP study back then. And but got to do some of the really preliminary experiments looking at the electrical isolation of implantable defibrillators in fish tanks. We were doing these models to see if the saline would corrode them or whatnot. And so I mean that again, all very motivational. And I said, look at the advances these people are making. Then again, a lot of people during internship and residency. Met Swan and Gans during my first fellowship. Forrester, P.K. Shah, many others that incredibly motivational. But then probably the biggest impact on my life was during my interventional cardiology fellowship, where I did a 4th year with Jeff Hartzler in Kansas City. And Jeff is probably, one of the most technically gifted, if not the most technically gifted operator that the field has ever known, was really pushing every boundary and suffered a lot of slings and arrows because of it. And that kind of fit my personality. And he's one of the most charismatic people that people knew. So he just drew people around him. And to see what he was able to accomplish by, pushing, again, boundaries and working at the edge, and how he had to suffer, how he had to get through it, politically, academically, but still being incredibly, triumphant and being able to advance the field of interventional cardiology. I mean, Grunzig developed balloon angioplasty, coronary balloon angioplasty, but it was really Hartzler that brought it to AMI and CTOs and multi-vessel disease and beyond. And so that was probably the single most transformative year that I had in Kansas City. And then I've just been very fortunate at every other step in my career. Probably the other single biggest influence was Marty Leon, who I joined now, about 20 years ago, first at the Washington Hospital Center, and then we moved to New York, and now at Columbia University. And we run TCT together and a research foundation and do a lot of, hopefully, impactful work.
Yeah, an incredible legacy. I didn't know someone from Ohio could go to Michigan, though. I didn't think that was allowed.
Well, that's very funny because my parents went to Ohio State, my brother went to Ohio State, so I had to go to Michigan. I had to be different. Okay. And that kind of tells you my personality. And yep.
So CoAPT aside, you've been the national, international PI for over 100 clinical trials. Can you sort of name maybe the top 3 other than CoAPT that you think had the most impact?
Well, it's interesting. I'll tell you one story before that. It's because people ask me a lot, why do you do this? Why do you do randomized trials? And that was one of the more kind of impactful early experiences in my career, because when I was starting my clinical and academic career, I was started, as a lab rat. I loved being in the cath lab doing complex intervention. That was the Jeff Hartzler legacy. But his other legacy was that he created a database. He had one of the first early databases at the Mid-America Heart Institute. And it was the database of thousands of patients that had undergone balloon angioplasty that he would report on honestly and transparently, the pros and the cons at scientific meetings. But nobody was running randomized trials back then. I even remember Eugene Brunwald, one of the early 2 trials came out, and Eugene Brunwald, one of the icons of our time, basically said, this is never going to catch on. These are too complicated. They're not that much advantageous. So it's kind of a fad. But then, I was involved in some of the early randomized trials, including the CoAPT trial. And that was really the one that kind of opened a screen for me, because CoAPT was a trial of balloon angioplasty versus directional coronary atherectomy. And directional coronary atherectomy before stents, that was the big new intervention. You're too young, you've probably never done a DCA. but it was this big garden hose, 14 French-like device that we would put in the coronary arteries, and it would excise plaque, and it would remove a lot of plaque, and you would get stent-like angiograms. Gorgeous, very rare, you'd ever see a dissection, and you'd take out all this plaque. And we were convinced that obviously had to be much, much better than balloon angioplasty, which leaving 50% stenoses, dissections, and poor flow. And so the CoAPT trial was done, which was like a 1,000-patient randomized trial of balloon angioplasty versus directional atherectomy, and showed that directional atherectomy had more acute procedural complications and no better long-term results. So, and I said, oh my God, nobody thought that was possible. And it just showed the power of randomization. And then the second one was early in my career. I got very involved with Bill O'Neill and Cindy Grimes, two other fantastic friends. It's hard to think of them as mentors because they're such close friends, but in the original PAMI trial, so the PAMI 1 trial, a lot of the early work I did was in acute myocardial infarction. And at that time, of people who were receiving reperfusion therapy with acute myocardial infarction, it was probably 99.5% were receiving thrombolytic therapy. And primary angioplasty, this is now, in the mid to late 80s, was barely being done. It was kind of an oddity. A few people, it was really introduced by Hartzler, who did the first acute infarct angioplasty. Bill O'Neill picked it up. But who would take the time to rush somebody having a heart attack to the cath lab? And that can't be a safe thing to do. And then, thrombus, and putting balloons in, how could that, be beneficial? And most people thought it was heretical to actually do that. And so we ran the PAMI trial. And I was one of the co-principal investigators of PAMI, which was the first randomized trial of balloon angioplasty versus thrombolytic therapy, TPA. And it was about 260 patients, and it showed a clear and major reduction in death and recurrent myocardial infarction with PCI, and a lot of other benefits as well. And that literally, almost overnight, changed how the world started to view and treat acute myocardial infarction. And still to this day, in terms of coronary intervention, the greatest thing that we do is treat acute MIs. Yeah, that's where we have the biggest effect on mortality. Also somewhat in non-STEMI. So I did a lot of studies. We went from that to stent PAMI, and then to Cadillac, and to Horizon. So a lot of big, large-scale, multi-center trials looking at better technologies and adjunct pharmacology to help fine-tune the primary PCI procedure.
What about, do you have any advice or guidance to the fellow, he or she, finishing up, going into practice, but who wants to participate, in clinical trials? Is there sort of a recipe for success or a way to kind of get started for these guys?
Yeah, so it's first of all, a lot of fellows will, quote, only go into practice, and that's great. And I'm always telling the fellows, you've got to be true to yourself. You've got to know what you enjoy doing. Medicine is a difficult field right now, and there's a lot of demands on us physically, in terms of sacrifices with your family, et cetera. And so you've got to enjoy it. You've got to have a passion every day you come to work. So you've got to decide, do I want to be a full-time academician, whether it's basic science or clinical research? Do I want to spend all my time in the cath lab? Do I want to spend all my time interacting with patients in an office, locked up reading films in a radiology department? But be true to yourself and know what you want to do that's going to make you happy. That said, I do think that for those people, and that's most of the people who choose a practitioner track, it's really critically important when you look at what your 30 or 40-year career is like, to realize that you've got to keep up. And there's going to be tremendous advances in medicine, both new devices, new drugs, techniques, and ways to diagnose the patient. Imaging revolution is extraordinary now. And the best way to keep up is, yes, you can go to conferences and you can read the journals and talk with a lot of smart colleagues, but the best way to keep up, I think, is to actually participate in clinical research. So I'd still recommend that people can still, even in a very busy clinical practice, can have a research infrastructure around them, whether it's a small local community hospital or a bigger academic medical center, and enroll patients in the newest drug studies, newest device studies, newest technique studies, strategy comparisons, whatever. And it keeps you engaged, it keeps your mind thinking, it keeps you at the cutting edge. And whether it's NIH or whether it's industry, if you're seen as a person who wants to enroll patients and wants to take an active role, you won't have to find them. I mean, they'll find you. Because especially in the United States, those people are like gold. And we love working with young physicians who want to get involved in research. I mean, that's how I started. I mean, I started in a small community hospital in California, and enrolling all my own patients, consenting all my own patients, doing it all, and because I was passionate about it. So I think that it takes some time and it takes some effort. So I mean, it could take up 10 or 15% of your time. So you do have to decide if you want to make that commitment. But I really do think it pays dividends. And then if you want to take it to the next level, almost all larger multi-center study groups, if you enroll a lot of patients and you show a lot of enthusiasm, you'll be able to first author, abstracts, manuscripts, et cetera, present at national meetings, and that can then take your career to the next level. So it really is just more of a matter of enthusiasm and deciding that you want it and that you'll spend the time on it, and then you talk to me, Marty, anyone else who's doing it a lot that's found a way to combine clinical practice with a clinical academic career. It's harder to do it with a basic science career, but clinical research with clinical practice, and we'd love to talk to you and give you career advice and introduce you to people, and it's really a very open and welcoming community, I really think, and that's one of the things that makes medicine special.
I mean, that keeping up part is really important. One of the fellows asked me the other day, when's the last time you put a bare metal stent in?
Yeah.
I was like, it's been a few years,
yeah.
And they're telling me about guys putting in bare metal stents, and I'm like, well, they probably haven't read a journal in 10 years.
Absolutely.
I mean, there's almost no role for them anymore.
Yeah.
So going to CoAPT, which we obviously you did an incredible job presenting that to us. If you had to go back and change anything in CoAPT, which we all in life, if we had a second chance, would change anything or add something. Is there anything in CoAPT you feel like you would do differently now that you know what you know?
Yeah, it's a great question. I mean, it was a very rewarding study. It's of all the trials I've led, it's one of the most positive. And all randomized trials have tremendous value, whether they're positive or negative. And about 75% of randomized trials are negative. Actually, most of them are. This one was not only positive, but it was extraordinarily positive with even a mortality benefit. So I think that I wouldn't have done too much different. It'd be hard to criticize the success of the trial. Probably the biggest regrets are that it took 4.5 years to enroll, and it was very difficult to enroll. I would have liked to have had it be an international effort. I think that if we had, it was only U.S. and Canadian sites. I think that had we, taken 40 additional top European sites, that it would have enrolled faster, and we would have gotten even more global representation. I like most of my studies. I like to be international for that reason. So I think that could have been done differently, and then hopefully we maybe could have enrolled in 2 years instead of 4.5 years. I think that it would have been interesting, of course, in retrospect, given how positive it was in this very narrow group of patients, to have been able to study other groups of patients. I mean, 614 patients randomized. It's actually the largest randomized mitral trial ever done, which is but it's still a small study. It's still only 614 patients. So it would have been nice to include asymptomatic patients, patients with either sicker degrees of either more severe LV dysfunction, or the stage D patient, the bedridden patient waiting transplant, et cetera. Some of those, I guess, will be for future CoAPT trials or other surgical or transcatheter repair devices. And then, as we were talking before, we had this fascinating screening registry and a whole eligibility process where it was hard to get into the study, and that was part of the reason. In fact, for many of the sites, it was kind of daunting because they had to present their patient to some of the top heart failure and top surgical and interventional experts in the world. And they were kind of put through the grill saying, well, this patient's got an EF of 25%, and they're not on spironolactone yet, and your dose of beta blockers is too low, and And they said they had a rash. Well, did you try to switch to this compound? And so they really, the eligibility committee, especially on the heart failure side, pushed very, very hard to make sure that the patients were on really maximally tolerated doses of all class 1 guideline-directed heart failure medications, cardiac resynchronization, defibrillation, and revascularization if appropriate. Yeah. So we had, so it was a fantastic process. It's one of the reasons it took so long to enroll, but it's one of the reasons we got the right patients in the study. And so I'm running like 3 other studies right now where we're using central eligibility committees and having the same kinds of frustrations, but I know we're going to end up with the right kind of patients as long as we can stick it out. I wish we had kept an outcome database of the patients that were presented to screen that never were enrolled. Because we actually, one of the things we've really learned in this whole process, as much about the mitral clip, is how important, appropriate heart failure medical therapy is, and optimization. And, anecdotally, we heard that a lot of those patients that got presented to the eligibility committee who were had severe MR and were symptomatic but were not on optimal meds, that once we gave the advice on how they should optimize their medical regimen, that they got better. Either their MR went from 3 to 4 plus to 2 plus, or they became asymptomatic and so no longer qualified for the study. And that's fine. But I wish, I suspect that happened at least in 50% of the cases. But I wish I had those numbers and that data. Small things. I mean, I wish we had, MRI to have looked at a lot of the echocardiographic parameters. But, in general, this is one that you look back and feel good that you did most things right.
Yeah, no, I agree. And I mean, very, very rigorous, which I think to the trial's benefit, really getting people in. Regarding, just kind of a side question that came to mind, regarding international participation in large randomized clinical trials, where do you see China fitting into this? Because that's a huge opportunity potentially for collaboration.
Absolutely, it's a great question. So we do a lot of work with China. I'm probably in China twice a year and have very close collaborations with 4 or 5 of the leading interventional cardiology scientists in China. And they're impressive people. And, with a population of 1.4 billion, they are, their volume of angioplasty and, their government's commitment to getting better care for the populace is actually really impressive. And, they, a few years ago, they were, maybe 10 years ago, they were doing, 20, 25,000, angioplasties for the whole country. And now that number's, about 800,000, and it's going to surpass the United States and be #1 in the world pretty soon. And it should be, of course. I mean, there's a lot of coronary disease. It's a huge country, and they've got challenges spreading out to the rural areas. But that said, you asked me about research. So there is a real hunger in China to want to do good research, good clinical research. But honestly, they don't know how. And, they've come to us and others to try to teach them good, GCP, good clinical practices for research. And we put on courses there. We're working with them. We'll mentor them. I'm, the co-principal investigator on 3 studies right now that are ongoing in China, with a Chinese lead. And they will enroll patients very rapidly. Right now we're doing a study called Bright 4, which is, enrolling 6,000 patients with AMI and retesting bivalirudin. Something that a lot of the world thinks has been done, but the data is very conflicting, and I think this is going to add a very important piece to that. They're doing fascinating things in pulmonary denervation. They developed a whole new therapies to treat pulmonary hypertension that they were the first in the world to develop that. They've got, because of somewhat less rigor in some regards for regulatory aspects, they've got a lot of companies doing a lot of creative things that are difficult to translate so far outside of China. But we're starting to bring Chinese stents and other devices into the United States. And we're working with them on randomized trials in the US. There's some very good Chinese companies that are making excellent products. So the answer is, I think in the future, their research infrastructure is getting in place, is increasing. They, 30 years ago, I didn't know how rigorous research had to be. I thought, you kind of do it. You could be a little sloppy, but you can't be sloppy. There's no room for sloppiness anywhere. You've got to be incredibly meticulous in every aspect of the whole research complex, and they're starting to learn that, and they're starting to overcome that learning curve. I mean, to do good clinical research is challenging. And, protection of human rights, having the right IRBs in place, to get to the point where FDA will accept data coming out of China or out of India or out of some other countries, which they haven't traditionally accepted. I think we're going to get there. It'll take a few more years, but they're well on their way.
Okay, great. Yeah, we just trained on the J valve, which is made in China. That's it's interesting that it's
absolutely.
Chinese devices are coming to the United States.
Yep.
So in closing, we've already talked about it a lot, but you're very active and, to me, valuable on Twitter as far as a resource and learning. And just maybe you could highlight some of what you see as the pros and cons of Twitter and interventional cardiology.
Well, it's funny. As I was telling you yesterday, I was hoping to get through my whole life without having to do any social media. It's I tend to be a private person. I love people, but I also, just don't. I think it's obtrusive to say where I went to dinner and I enjoyed this bottle of wine. I don't know. It's just not my personality. So social media was really never for me. But people were always saying, look, you spend so much of your life educating, and I do. I run a lot of conferences and devote a lot of time to TCT and grand rounds here at Houston Methodist and others. So they said, this is an amazing way to reach people. So, I kind of always said, okay, I'm only going to do it if I have something intelligent to say every day. And so I started doing it maybe about a year and a half ago. And the first thing I found out is it's hard to come up with something smart to say every day. And it takes time. It's actually really not that hard because we all have a lot of interesting thoughts, but I'm not going to put drivel out there. So I'm going to, find, interesting articles that got me thinking and let people know about that, and not trying to be authoritative. I say, look, this showed this. What do people think about this? And it starts a whole conversation. I've learned that, in about a year and a half, that it's actually a tremendous medium to reach a lot of people very quickly. And while I still think the minority of cardiologists and physicians are on Twitter, it's definitely increasing, and I think it's going to continue to exponentially increase. And you have some amazing discussions, and you can learn tips and techniques, and people put up fantastic films and cases that you can learn from. None of it's peer reviewed, and some of it is out there. So you've got to, have a good filter to know what's real and, what's a little at the far edge. And yes, Twitter can be a nasty place, and there's a lot of people that, because they're not standing in front of you, they'll say some pretty outrageous things, so you got to have a thick skin. But that being said, I can tweet something in a day or two, it'll reach 25,000 people.
Yeah,
and that's, and it gives you the metrics, so that actually is motivational, and it says, wow, this is having some kind of an impact. I think it's a social environment that people should learn on, especially professionals. I think professionals are really using Twitter. Younger people, social, are Instagram, Facebook, etc. And I still don't see. Hopefully, I'll get through life without Instagram and Facebook. We'll see. But at least Twitter, I've actually found to be fairly rewarding.
Yeah. So your next task here today is to get Neil Kleiman on Twitter.
Okay, I'm going to work on that. I'm going to work on it.
Thanks again for your time.
Great,
I really,
Thank
really
you.
appreciate it.
My
Everything
pleasure.
and all your insight.
Thanks.